and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. Coming in 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3, 2,
1.
And here we're live. Happy New Year. Happy 2025. Today is January 10, 2025. I'm Jens Chapman from the Seattle Science Foundation. And this was going to be a highly celebratory day where we recognize the great work of Dr. Jeff Wang in founding the Global Spine Journal since 2011. We've just had our millionth download, which is an incredible accomplishment. I want to recognize AO Spine International, but particularly the vision and the very effective leadership by Dr. Jeff Wang. Of course, all of our thoughts are with you in LA. When we say live from LA, we envision a phenomenal scenery, and it's obviously been marred by these fires. So we're live from LA with an aching heart. Good morning to you in LA, and thank you so much under these dire circumstances to make the time and effort to educate us on the articles that that you've selected from the Global Spine Inventory to discuss minimally invasive spine surgery today. So good morning in LA, and thank you for doing this session. And thank you, Jeff, for all you've done for the journal, and congratulations on this milestone success.
Great. Well, thank you, Jens. First of all, thank you for all of your support and help over the years. And as a co-editor in chief of the Global Spine Journal, you are a large part of the success of the Global Spine Journal. And number two, I want to thank you for driving this journal club for the Global Spine Journal. It's something that you created. It's your brainchild, and it's something that has been very successful, even though we've only had a few so far. I certainly look forward to any future ones, and we're certainly happy to participate. And thank you for creating this and working with the great folks at the Seattle Science Foundation to get this disseminated, because I do think that science and literature are so important. It's important for us to learn how to make advances in patient care, but at the same time, we have to look at these studies critically, because people are reading these and making these clinical decisions based on the literature, and the young surgeons are making decisions on what types of procedures to do, and they're basing it on these studies. And we have to really pick these apart to make sure they're the highest quality and look at the good parts and the bad parts. So I just want to thank you. Thank the audience for participating, and thank the Seattle Science Foundation. As far as our team here, we have 3 amazing spine fellows this year. You can see them on the screen. One is Dil Patel. One is Matthew Igbeniji. I hope I pronounced that right. We call him Doc Iggy. And we have James Yu. 2 of these guys are orthopedic trained, and one is neurosurgery trained, and they're all 3 outstanding fellows. And so I want to thank them for selecting the articles, and we'll get right into it. I'm going to turn it over to you guys and have you start with the first article. This means it's up to you guys to start talking.
All right, can everyone see my screen?
Yes.
All right, so I'm Dil Patel. I'm one of the surgical fellows here, orthopedic trained. I'm going to go over learning curves of endoscopic lumbar discectomy. Here's the full article, title and authors. This was published in 2024 in Global Spine Journal. Endoscopic spine surgery is an emerging solution for lumbar degenerative pathology. It's the ultra MIS with smaller incisions, less post-op pain, and shorter hospital stays. However, there's a limited uptake in the US and many parts of the world, namely due to the lack of experience with instruments and cameras, and especially surgeons that have limited experience with MIS techniques. This does require fluoroscopic guidance, so that could be a hindrance. And there's also initially high setup costs. Learning curves are unavoidable in endoscopic surgery, like any new surgical technique, and thus many fully certified spine surgeons in the US and around the world are unfamiliar with endoscopy, even today in high volume centers. So I think it's important to characterize the learning curves of endoscopy, as this may set up expectations on future training. The purpose of this study was to quantify learning curves of 3 lumbar endoscopic surgery techniques, 1 being transforaminal, 2 being interlaminar technique, and 3 the biportal technique. This is a meta-analysis of single surgeons series of endoscopic discectomies. They included measures of operative time and complications. They did exclude a series with more than 1 surgeon, microendoscopic or hybrid techniques, as well as anterior lumbar surgery. The learning curve analysis was performed by plotting operative time and complications against case number. The operative time was expressed via a exponential decay curves, and the complications were expressed via logistic regression models. There's 118 full-text articles that were screened, and this was funneled down to 13 studies which were analyzed for this paper, that 15 single surgeon series with 864 patients total. So we'll start with the transforaminal approach. Regards to operating time, the first case on average was about 95 minutes, and the plateau was 66 minutes. The plateau occurred at around the 59 case mark, and 80% of the learning occurred at roughly 21 cases. So here's a sort of a visual expressing that it takes about 60% or 60 cases to plateau, and 80% of the learning actually occurs very early on, denoted by the blue line here, and that's around 20 cases. For complications, there were 26 complications in 201 patients, most commonly being dural tears and nerve root injury. There was a significant association between case number and surgical complications. The first case was expected to have a 25% complication rate with this logistic regression model, and it took about 42 cases to have an 80% improvement in complications. For the interlaminar approach, for operative time, the first case was about 85 minutes, with a plateau being 42 minutes. So similar to the transforaminal approach. The plateau in this series was 64 cases, and 80% of learning was in the first 23 cases. So the two big numbers to take home are 20 and 60 cases, which are similar between the two approaches. For complications, there's only 6 surgical complications that were reported in 117 patients. Because of this low number, there was no association with case number and surgical complications that was statistically significant. The first case had an 8% risk of complications, and there was an 80% improvement by 70 cases. For biportal technique, the first case was 154 minutes, and the plateau is 87 minutes, so almost double the time compared to the other two approaches. However, interestingly enough, the plateau and the learning curve, the early learning curve were roughly the same at 58 cases and 21 cases respectively. For complications, there's 9 surgical complications reported in 187 patients. This was statistically significant with association case number and surgical complications. The first case being 18% risk of complications. There's an 80% reduction by 42 cases. So I know there were some busy slides earlier, but this kind of pares it down. The two big numbers I want everyone to take home is 20 cases and 60 cases. Very interestingly in this paper, it doesn't matter which technique you employed, the mastery of the learning curve, which is around 60 cases, was about the same in all 3 of the different techniques. And most of the learning occurred, and 80% of the or 80% of learning occurred in only the first 20 cases. So pretty rapid learning curve, which is similar across the board. The strengths of this paper is a relatively large analysis with multiple single surgeon series, kind of the first of its kind. And the limitations of this were the heterogeneity in patient selection, the pathology and anatomic levels, which are difficult to control for, which could lead to biases. So the clinical application for this, or the question you want to ask yourselves is, what is the best way to shorten the learning curve for trainees and young attendings? This paper, the authors, they mentioned 4 different models that could be employed. The one is sort of the gold standard master apprentice model, which we see in surgical training today. However, this is not possible to employ just yet in the US, just because endoscopy isn't as widespread, and even a high volume surgical center that does a lot of MIS surgery like USC, we only do maybe 1 or 2 endoscopy cases a month, if even. So to employ this model, I think you need a more widespread endoscopy across the nation to be more uniform. The next model proposed was the cadaveric courses, which are very common in my training as a resident and fellow. However, a lot of the cadaver courses are focused on implants such as pedicle screws and inner bodies, and not so much decompressions. So I think we do have the resources in the U.S. at least, but we have to kind of switch the way we use our cadavers and focus more on decompression, which is important for endoscopy. Surgical simulators could be used in the future. Actually, in my residency program, we had surgical simulators for arthroscopy because I was orthopedic trained. So for shoulder, knee, and hip, we had these kind of hard models that we could go and use sort of the bony landmarks as kind of hard feedback. We had the screen in front of us, similar to endoscopy, where we could switch up the pathology. So it could be a rotator cuff repair or different various types of soft tissue surgery we could do using a similar instrumentation. So and I think it's a very low risk scenario, but there's obviously startup cost. And the last model that was proposed was remote video supervision, which I think could be a very nice technology to use in the future, especially since COVID. We are doing a lot of sort of remote conferencing, and I think as a first year attending, when you're in the OR, I think someone far away can kind of zoom in and kind of walk you through the case based on the images on the screen, which they can probably see remotely and guide you through very safe surgery. And that's all I have. Any questions?
Yeah, so thanks, Dill. You know, one of the things, I mean, obviously, as you know, being here at USC, we've just in the last few years, gotten through this learning curve and trying to deal with it and figure out how this fits into our practice. And so this is very applicable to what we've just gone through in the last year or two. You know, I was a little surprised by the findings of this study, and I wonder if you had any comments on the fact that, because I mean, it's kind of interesting talking to the people here, the attendings here. You know, as you know, one of our neurosurgery partners basically thought, hey, I'm going to start interlaminar because the anatomy is so much more familiar. because his rationale was, I do that interlaminar approach with the tube right now. I do it with an endoscopy. If I get in a difficult situation, I can abort. I can just drop a tube through kind of the same incision, just enlarge it a little bit. And then many of us started off with the transforaminal because when we learned, from company courses and courses that we've taken, everyone says the transforaminal is a little bit easier. And so I was a little surprised that the learning curve is pretty similar between all three approaches. And what are your thoughts on that? I mean, does that mean that it's really not the anatomy we're getting used to, and it's really just the use of the tools and the endoscope?
I totally agree with you. I think I don't think it's the anatomy. I think it's just getting used to the workflow and the tools and the new approach, docking the endoscope. I think that's probably the large portion of the learning curve as we are very familiar with the anatomy. From the transforaminal approach, a little bit different than what we're used to looking at, which is a traditional interlaminar. But I think as this study shows, it only takes about 20 cases to feel comfortable with any of these three approaches. So, which is very reassuring.
And I see we have a question. We have a resident, Kareem Kabash. And I apologize if I'm mispronouncing your last name, Kareem, but he has a question for you. Kareem is one of our fourth-year orthopedic residents. He's outstanding, and he's applying for spine fellowships. So for those of you who are viewing this, if you see him coming through your program for an interview, please take a close look at him. Kareem?
Thank you so much, Dr. Wang. Dill, my question for this article was, with there being an estimated 70 cases required to reduce the complications by 80%, which I thought was quite high for 90% of surgeons, is there any role for having a mandatory co-surgeon who's met these minimums, have mastered these techniques? Is that feasible, or is it reasonable for a medical legal standpoint?
Yeah, I think that's a very good question to ask. I agree with you. It takes about 70 cases to sort of master the learning curve as far as complications goes. But with the beauty of endoscopy is you have a screen, and as long as you can dock the endoscope in the right position, there could be possibly another surgeon they don't even have to be in the same room if they can kind of remotely view what you're seeing on the screen and be able to successfully guide you through the operation. So I think with today's technology, especially after COVID, I think we can really use it to our advantage with remote surgery and assistance.
Hey, Jens, I want to turn it over to you. Are there any questions that are coming through the internet or the chat?
So we had a great question along the same lines, but let me just expand it a little bit to the group. Dr. Michael Russell asked the same question, that is, this learning curve, which is again a euphemism for complications, which this article at least underscored correctly, seems pretty high. And I concur with Dr. Russell's assessment. Dr. Wang is former president of NAS and many, many major organizations around the world that you have led. If you were reviewing somebody's case files as a board examiner and they said that they had 20 complications or 20% complications or more in their first 40 cases for discectomies, for routine discectomy, would you consider that high or low? And what's the comparison to a standard mini open procedure?
Yeah, no, that's a great question. And it's a difficult question because, it is a new procedure. I would think that that's high. Obviously, if you're a patient and someone tells you the complication rate is going to be a certain amount and it seems kind of high, you probably would start thinking a little bit differently about that particular surgery. I do think that this is kind of something that I've wrestled with over the past 2 decades. As we all know, endoscopy has been very popular outside the United States. And if I think back to 20 years ago, there were a few people really pushing endoscopic surgery in the United States, and they were not considered the mainstream surgeons, and they were very vocal about it. And I kind of asked myself, like, why aren't we adopting it more? And with all due respect to the early pioneers in the United States that were pushing endoscopic surgery, I think part of it was just the general political acceptance of the procedure. And I think a lot of the leaders at that time of the organizations and kind of the thought leaders at the time were kind of against it. So I do think there was sort of a political thing. But I kind of think that we're breaking down those barriers now. I can't really comment. I mean, you know, NAS never restricts practices. So I don't think any of the societies would ever kind of intervene in here and say someone couldn't do something or couldn't or can do something, because they've been very strict about things like that. But I think it's something that we all have to wrestle with. I can tell you, having just started endoscopic surgery in the last 2 years, I'm very open with my patients. You know, the first one I did, I said, listen, this is my first one. The second one, I said, this is my second one. And, you know, we might enter complications. The complications might be a little higher than someone who's more proficient at it. And so I just think you have to be very transparent with your patients. I don't know if that answered your question, Jens.
Now, we don't have an answer. My biggest concern is, statistically speaking, these are, as you had said, and by the way, this is a terrific presentation, Dr. Patel, and great question, Dr. Kabaish. These are very driven colleagues from which these statistics were culled, and that's a representation of efficacy as opposed to efficiency. That's when it gets out into the common field. So these are very valuable foundations. I think this is a really helpful resource article, but it's also something that should give us pause, because these are more expensive procedures. And I don't know how it is for you, but I do many open procedures, and the patients are expected to go home within 4 hours, and they do. So I'm really not sure that a lot of these extrapolations that go into the mainstream come about with a justification in the general field of practice. Again, the efficiency versus efficacy.
Yeah. Okay, so sorry. I think we should move on. I just looked at the time, and I think we should probably move on to the next article. But great presentation, Dill, and I think that's a great discussion.
Thank you.
Who is next?
I'm next, just getting set up here. 1 moment, please. I have to log out. I'll be right back in.
Does Matt have the next 2 articles? Dill, yeah.
Let me just ask whilst he's reloading, Dr. Kabaish, you're looking for fellowships. You're a young, hungry fellow surgeon at a prime program in your country. How much is proficiency in endoscopic surgery relevant for you in your selection of a program?
I think it's an important factor. I think it's, you know, it's tough to know what I'll be doing full time in practice and how my practice shapes up. But I think at least some exposure to the techniques that allow me to be able to perform it at the beginning of practice, knowing that there will be a learning curve, is important to me. So I think at least some exposure to be able to hit the ground running to some extent.
Okay, Matt, are you ready?
Ready. Apologize for the delay. My name is Matthew Bennigy. I'm one of the orthopedic trained spine surgery fellows. I'm going to review this systematic review and meta-analysis comparing endoscopic versus minimally invasive or microscopic spinal surgery. The goals of this study were to compare the outcomes of endoscopic surgery, both biportal and uniportal, to microscopic techniques, and hopefully examine some of the safety, efficacy, and postoperative recovery differences. We all know what lumbar spinal stenosis is, essentially hypertrophic degenerative changes of the lumbar spine, leading to debilitating back pain, neurogenic claudication, and overall decreased function. The indications are warranted when pain is irretractable and non-amenable to conservative techniques. Microscopic techniques are typically tubular, in which a tubular retraction system is used, and microscopes are used to essentially assess the tissues and complete the procedure while sparing soft tissues compared to conventional techniques. Whereas endoscopic techniques use even a smaller window, whether it be through a uniportal or a biportal viewing, a biportal working space, which is kind of depicted here. So getting into the study, this is a systematic review with meta-analysis of data using four database search systems, which were coming out of PubMed, MBIS, Cochrane, and the Korea Med. The inclusion criteria were for studies that essentially used these two techniques and had viable data. Outcomes that they looked at specifically were the visual analog score, the Oswestern Disability Index, hospital stay, complications, and operative time. Of these studies, 11 were found to make it through the selection process. 3 were randomized control studies, 6 were retrospective cohorts, and 2 were prospective case controls. Of all of these, they had about 1,000 patients, with a bias towards endoscopic patients. And they primarily looked at those 3 things that we mentioned in the previous slide. So looking at the results, in terms of hospital stay, there's a bias towards, there was a trend in favor of endoscopic surgery, which you can see the main differences with biportal surgery, just a little bit longer than uniportal surgery. They attributed this to the less invasive approaches and the use of local anesthesia versus conventional means. Now, comparing their postoperative pain using the visual analog score, they didn't see a significant difference, but they did see data in favor of endoscopic surgery in both uniportal and biportal techniques. In terms of functional outcome, they also didn't see a significant difference, but again, another data was in favor of endoscopic techniques. Operative time was the only parameter that they saw in favor of minimally invasive techniques, and they only saw about a 5-minute difference. Endoscopic technique surgeries were up to 160 minutes in some of these articles, and minimally invasive techniques were mainly up to about 90 minutes. In terms of complications, they saw that the complication rate between the two were vastly similar. However, there were some unique complications to endoscopic surgery, specifically in spinal headaches, in which they believe that due to the increased pressure, there was also, the increased hydrostatic pressure with using the endoscope, they felt that this transferred to the CSF canal. So some of the advantages that the article purported for endoscopic surgery were kind of as listed: reduced hospital stay, which intuitively is likely due to smaller incisions, percutaneous portals with less soft tissue damage, and the use of regional anesthesia versus general anesthesia. They also inferred that decreased paraspinal muscular injury could be, correlated to systemic CPK levels, which obviously were not done in this study, but was inferred based off previous studies. So some of the challenges, you kind of go back to Dr. Patel's article, is really the learning curve. Obviously, operative time was a little bit higher in these surgeries, but this learning curve could kind of explain some of the degree of complications that are seen because of the narrow working space and the demand to be acclimated to the special equipment. And then obviously the unique complication of CSF pressure headaches. So some limitations of the study are pretty obvious. They only had 3 randomized control studies that were included. And the heterogeneity of the studies were unfortunately biased towards endoscopic surgery. So I think, in terms of looking to the future, a higher degree of randomized control studies would be helpful in elucidating the data of this study. But the overall conclusions, I think, are still pretty clear that endoscopic surgery seemed to, have a shorter hospital stay without a significant difference in complication rates, and prove, I think, potentially in the future to be a viable standard of care for these types of patients. So for a young surgeon, I think the implications are, not truly defined by this study, but I think it's suggestive that as a young surgeon, this is something that we should keep our mind open to and potentially seek mastery of as the patient population becomes more aware of its existence and benefits. And I think I've already discussed this, so I'll take any questions at this time.
Yeah, so Matt, first of all, very nice presentation, very nice slides. I like your use of the pictures. It's very nice. As far as the actual article, when I read the article, was this basically just decompressive surgery, or did they include fusions? Because when I read the article and I look at the discussion, it appears it's mostly just decompressions. But when I look at the hospital stays being up to close to 3 days, it almost makes me wonder if they did fusions.
Right, and from all that I can see, it's all decompression related surgeries, which is
So doesn't that length of stay just seem kind of high for just the decompression? As Jens mentioned at the beginning, he does a mini open or I don't know, Jens, you use the tube or you just do like a small incision, and the patient, you said, goes home in 4 hours. Is it a little surprising that we have like hospital stays that are like 2.9 days and things like that?
Let me pipe in there. I think this is a really important factor because I think we should always look at the raw numbers when we see these studies. And this is very important because surgeons like ChatGPT draw their conclusions from published data, like what we have in Global Spine Journal. So we're creating evidence, and this is guiding practices. When we see numbers for discectomies of several days, that's an anachronism, or it's a severe selection bias where really sick people or people with complex problems are put into that pile. So this is a really important thing to look at the source numbers and see how they fit into your cultural environment. And especially in a global realm nowadays, and again, we're talking about the Global Spine Journal, so these are articles from all over the world. This is very relevant because you have to ask yourself, does this fit into my experience? Does this fit into our cultural environment? And when I see these numbers, I was actually going to ask the same question and make the same statement that Jeff just did. 2 to 3 day hospital stays after discectomy, that's not our clinical reality in the US anymore. That's just not there. There's a story behind it, or it's a different cultural expectation or a different time period.
Yeah, I would agree. Matt, any comments to that, or is it kind of just is what it is?
No, I completely agree. I think that even though the study was published 2 years ago, that still is a very high hospital stay. Here at USC, our patients go home routinely the same day unless there's some form of a complication. So I think that is definitely an odd thing that came up. That's why I think the study would definitely benefit from obviously more randomized control studies, a deeper look into these actual papers, and potentially regional control in terms of like the stays.
So I know Dr. Kabash has a question. Kareem, am I pronouncing your name right? If not, please correct me.
No worries, Dr. Wang. It's Kabash.
Kabash. Dr. Kabash has a question.
Thank you so much for the presentation, Matt. My question for this article was, does the lack of the surgeon-specific data, and the study actually mentions that there's a bias in their publication with regards to pain scores, do you think that weakens the conclusions of the study of them finding no difference in the outcomes?
Yeah, absolutely. Yeah. I think there's a lot of heterogeneity in terms of the selection. And obviously we all discussed that there's this bias towards endoscopic. So I think the reported differences are, less reliable for that same reason in terms of what you're talking about.
The other comment I just want to make, and this is more of a generalized comment, and it kind of takes into account the last article we looked at. Whenever you look at like the comparison of two procedures, so here we're looking at endoscopic versus sort of minimally invasive, sort of more traditional approach. Whenever you look at those two things, what you have to take into account is the surgeon's experience. And what I always tell patients, if they come to see me and they say, well, this doctor recommended this procedure, this other doctor recommended this other procedure, what I always tell them is, you have to go with what works best in that surgeon's hands. So obviously, if a patient looks at this and says, well, geez, I would like to have an endoscopic surgery because the hospital stays, shorter, the damage to my muscles is less, and so I want that, but their surgeon has no experience or very minimal experience in endoscopic surgery, I'm not sure it's safe or appropriate for them to just demand an endoscopic surgery. Obviously, it might be better to go to someone who maybe has more experience. But I always look at these comparison studies and just say it's important to know the differences between the two procedures. But also, when it comes to you, if it's one of your family members, you want to look at the surgeon's experience. Jens, any questions from the chat?
No, but I put up something on ChatGPT. Lumbar discectomy, what is better, endoscopic or microscopic decompression? And I always love doing that because it, again, summarizes the literature actually very well. And it's basically identified what Matt just pointed out, and that's the observer bias. It said that the gold standard remains microscopic surgery. I was amazed by that differentiated approach, especially for complex cases and revisions. And endoscopy is maybe better for simpler cases in experienced hands, but it identifies as one of the biggest drawbacks, and I see that in the lab, lack of proprioceptive feedback. I thought that was an amazing insight, and again, that's ChatGPT speaking. So a impartial AI-driven summarization.
Great. Okay, Matt, I think in the interest of time, we'll just have you push forward with the third article.
All right. So the next study looks at, it's a prospective single center study looking at open versus minimally invasive TLIF. We know this procedure has multiple indications. And so conventional is typically open midline incision versus MIS, two paramedian incisions. Specifically, this study looked at the multifidus muscular atrophy, which was mainly purported because of was mainly focused on because of the function of the multifidus muscle and lumbar stiffness and stability with ambulation. Some studies have looked at essentially the concern for muscle injury after these procedures and observed atrophy, which was suggestive of potential function down the road, which really was the motivator of this study. So this is a prospective observational study at a signal center in India, where they had 100 patients who underwent single level TLIF at the lumbar level 4 or 5 or 5S1 for degenerative pathologies only. At the end of the day, they had 50% of patients in each group, in which they excluded patients who had any multi-level surgery, revision surgery, or non-degenerative indications. So the primary outcome measure for this was reduction in the lean muscle mass of the multifidus, which was observed in MRI 1 year after surgery for both groups. Secondarily, they looked at age, gender, and side of cage insertion to assess whether this correlated with lean muscle mass loss. They used a T2 weighted image at the level of the vertebral end plate for control, and they calculated the ratio of the vertebral body surface area to that which was observed in the multifidus muscle. Statistically, they used standard statistical means to assess the data. And so in terms of their results, they saw that overall conventional open procedures had a higher rate of lean muscle mass loss at 1 year. And they felt that this difference was statistically different. They saw that the cage insertion side had a higher reduction versus the contralateral side, which was also statistically significant in this study. They found that the age had a weak correlation, but however, they saw that older patients typically had higher muscle loss. And they saw that females compared to males had a statistically different increase in muscle loss at 1 year. And so, this study kind of suggests the advantages of an MIS technique is that you have, a reduction of muscle injury by way of MRI over a year, which could translate into functional means given the function of the multifidus muscle. And secondarily, they believe that this could potentially protect patients from adjacent segment disease, which usually leads to a road of revision surgeries. Some of the challenges kind of are reiterated from the previous studies is really the technical demand of these procedures. I think secondarily, they mentioned the risk of asymmetric atrophy, which could potentially lead to clinical differences, but I think that's just something that's secondarily maybe not as significant in this study. So the key findings is that conventional open procedures typically in this study showed a higher degree of lean muscle mass atrophy within the multifidus, primarily in older patients who were female as well. But up front, we see many limitations in the study. It's a single center study, non-randomized, with only 2 surgeons. And so, additionally, they don't put any kind of functional correlation, which they are suggesting within the data. And so I think that gives a lot of room for the future in terms of what studies that can be done. So I think for this study, that is the main data that I'd like to present from this study. I think I'll take any questions at this time for the interest of time and get into the next studies.
Yeah, so Matt, first of all, again, great presentation, great use of visuals. It keeps my interest when I see pictures. As an orthopedic surgeon, I love to see pictures. But I think my first comment is something that you just kind of identified is, and my answer, and I don't mean it to sound so contrite, but so what? I mean, it's not unexpected. I've seen these studies for the last 2 decades. Not so much for fusion, but with minimally invasive approaches using a tubular retractor, less muscle damage. They measure enzymes and things like that. So I think people accept the fact that if you're going to make a smaller incision and do things minimally invasively, there's probably less muscle damage. But I guess the question I have is like, so what? Meaning, and I don't mean to say so what, like it has no bearing, but what are the functional results of that? Like, what are the ramifications of that? And they really don't explore that in this study, right? Like they say prevents against adjacent segment problems. They're just postulating that. They don't show that. Does that mean there's less pain? I mean, I think, Jens mentioned he does his very small incision and his patients do well. I think you've seen a bunch of patients here. We do it through the tube. We do it mini open sometimes using the McCullough retractor. And these patients, we don't really see much of a difference. And I suspect if we looked at those, and compared those to maybe an endoscopic approach or something, we probably have less muscle damage. But are you aware of anything that, like, so what? Is it more pain? What are the functional ramifications of that?
Right. Based off the data presented, I'd say, I would agree with you. So what? There isn't much to say in terms of, how these patients actually manifest in their recovery process. I think, based off of their inferences, it begs a question that should be studied long-term in a more higher quality fashion. But this study alone, I don't think would change much of what I think I'm learning in what I'm doing as a surgeon.
And I know Dr. Kabesh, is that right? Did I say it wrong? Has a question for you.
That was perfect, sir. So Matt, my question for this study was the study team, in terms of methodology, it doesn't seem like the surgeons were blinded to which patients were enrolled in the study. Could that potentially influence the results of the study or cause bias in operative techniques?
I think inherently, yes, for sure. But I would say, based off of their 1-year MRIs, I don't think they were intentionally, making a more aggressive dissection for open versus MIS techniques. Obviously, there's not much data in terms of the years in practice each of these surgeons have, and we don't have clinical correlation in terms of the patients themselves. So, yes, there is a bias. I think looking at the MRI alone is interesting, and I think obviously this could be elucidated with further studies that were more randomized and pretty much higher quality studies. But yes, in short.
Jens, any questions from the chat room?
So first of all, Marvel, thank you for this very insightful presentation. I agree with Dr. Wang. I love the pictorials with it. I was questioning the methodology. How did they do this, that they got a 1-year MRI scan? I mean, we nowadays have to fight insurance companies to even get a first MRI scan. And so was this a funded study that they could get that repeat MRI at 1 year? And the second question is, how do they accommodate for artifact? Because again, there's hardware put in there, and we have done a number of MRI studies now on muscles in a different questioning, and it's very hard to kind of summate the artifact, the flare, out of routine MRI. So who funded this? How did this come about that they had a 1-year MRI, and how did they accommodate for artifact from hardware?
In terms of funding, I'm sorry, I did not actually see the source of funding listed within the study. It was a question that I had, but I did not see an answer to that question. There was no control for artifacts. I think, again, the MRI was done at that level, at the implant of the disc space. So I think more information about actually the implants used was also not, discussed in terms of what the graft was made of. But that again does add to speak to the quality of the study in terms of whether this is reliable data or not.
So we have a comment, and that's nobody less than Dr. Bob McGuire, our president of AO Spine International, who's kind enough to give us time for this. And he said, I full-heartedly agree with Dr. Wang's comment of so what. As you get more experienced, you don't ravage around the spine. You become very focused and decisive, but clear and clean in your dissections. And open is not destruction. And I want to second that also from my end. So thank you, Dr. McGuire, for that comment. What I think the main problem is that when we do, quote, open surgery, this should not be a Columbus surgery where we explore around. We should have a very clear target and do a very decisive and clean dissection. Empirically, I know that's not a fair statement. I do a lot of MIS revisions, so I have a negative bias that I have to disclose. But when I see these patients with like 18 incisions on their back, and then we have to revise that hardware, those muscles are dead. I mean, this is not some healthy, viable muscle. There has been a lot of rumination and a lot of trauma to those muscles. So I see this study, I acknowledge it, I appreciate it. I have my questions that I point out methodologically, but empirically, this does not match. It matters probably, but I would stay with the so what comment. I thought that was very poignant.
Great. And with that, I think we have 10 minutes left. We're going to move to the last article, and I want to introduce Dr. James Yu. James is one of our neurosurgery infolded fellows. So he's actually a neurosurgery resident. He's a PGY 6, I believe, in our neurosurgery program. He's spending the year doing our fellowship, and he's actually applying for the fellowship match. So he also will be interviewing with you, those of you out there who are fellowship directors. So keep an eye out for James. And James, take it away.
Thank you. Let's see here. So good morning. I'll be presenting the next article here. it's an article actually focused more on radiation exposure overall in lumbar spinal fusion, but since the various navigation tools such as CT and robotic assistance and fluoroscopy are highly relevant in MIS cases, this paper was pretty relevant for our overall MIS topic. It's an NYU paper from 2021 titled Radiation Exposure in Posterior Lumbar Fusion, a comparison of CT image-guided navigation, robotic assistance, and intraoperative fluoroscopy. So background-wise, accurate particle screw placement is critical for successful posterior spinal fusion, and freehand technique has a misplacement rate of 5 to 30%. Complications arising from misplacement include neurologic and vascular injuries, persistent pain postoperatively, potential revision surgeries, and higher costs. And the emergence of intraoperative fluoroscopy and in the more recent decades, advanced guidance, including CT and robotic navigation, have improved accuracy. However, there is limited data comparing radiation exposure to patients, surgeons, and OR staff across these modalities. And if we think about surgeons and OR staff who have multiple cases, multiple days throughout the week, these radiation exposure can quickly reach the annual limit over time. So the objective of this study was to assess radiation exposure and perioperative outcomes in posterior lumbar fusion using CT image guidance, robotic assistance, and fluoroscopy. For the methods, it was a retrospective review at a single academic institution spanning 1 year in January to December of 2018. And it involved 19 spine surgeons, both from orthopedic and neurosurgery departments. And as seen here, there is some variation in the number of cases performed by these 19 surgeons. And for the case selections, there were 165 patients included in the study, with the inclusion criteria being patients being 18 years or older who underwent either 1 or 2 level TLIFs. And the duration of the study really covered the initial hospital course with no follow-up data. In terms of the navigation or image guidance, there were 4 types being studied in this paper. The first being standard open surgery. There were 56 cases. There were freehand pedicle placement with fluoroscopy assistance. And then there were MIS cases that were all fluoroscopy. It's assisted 35 cases of them. The third was CT image-guided navigation. For this paper, the group used Aero, which is a brain lab product, and it was only open TLIF cases using the intraoperative CT navigation. And the CT scans were mostly from intraoperative spinning, but there were a few studies that included pre-op CT that were merged intraoperatively. And for the robotic assistance, they used the Excelsius GPS, a Globus product, which used predominantly preoperative CT that were merged intraoperatively with fluoroscopy. For the primary outcomes, the study reviewed preoperative radiation dose arising from preoperative CT scans, as well as intraoperative radiation dose from either fluoroscopy or intraoperative CT. And then the total radiation dose, which was the summation of preoperative and intraoperative radiation. And that total radiation dose divided over level fused in the surgery. The secondary outcomes included the number of levels fused, estimated blood loss, length of stay, operative time, and perioperative complications. However, there were no analyses involving surgical efficacy, such as reduction in pain or disability. And then the statistical analyses were univariate and multivariate logistic regression for categorical variables, and then one-way analysis of variance for continuous, with the significance set at p less than 0.05. Going over to the results, for the demographics, there were lower proportion of female patients in open and MIS groups. There were 38 in the open and 45 in MIS compared to 66 and 64 in the CT and robotic cases. And then there were younger patients in the MIS group, and there were no significant differences in the patient BMI or comorbidity index. I actually thought it was interesting that the BMI was pretty uniform across these groups, since I would assume that for fluoroscopy, especially higher BMI could potentially confound the results of the study. For perioperative outcomes, the lowest number of level fusions were in the MIS group, and then the EBL and the length of stay were also the lowest in the MIS group, which is intuitive. And the operative time was also lowest in the MIS group and highest in the CT open TLIF group. And then there were no differences in postoperative complication. For the radiation exposure, the total radiation and total radiation per level of fusion was highest actually in the MIS group, which was 82 milligray, compared to the lowest, which was in the open group, which was 22. And then the CT navigation and robotic assistance cases were in the middle with about 50 and 59. Intraoperative radiation was also the highest in the MIS group and then lowest in the open group. So for the MIS group, this would have been all fluoroscopy intraoperatively. And then the intraoperative radiation was similar in both CT navigation and robotic groups. The highest proportion of robotic cases, highest proportion of preoperative CT scans were done in the robotic group of 82, compared to just 37 or 25 in the open and CT navigated groups. So for this CT navigated group, the remaining cases were intraoperative spins rather than preoperative CT. And since the MIS group had the highest radiation exposure for both total and for intraoperative radiation, it suggests that the radiation exposure shared across the patients and the surgeons were the highest in both groups. And when we look at the fluoroscopy time data closer, there was actually greater variation in fluoroscopy time in the MIS cases. So we can see anywhere between 37 seconds all the way to 3 times that, over 106 seconds, based on the surgeon. Whereas if you look at the open cases or robotic cases, they were pretty uniform. And for the strength of this paper, first and foremost, the statistical analyses were very sound. But more importantly, I thought it was pretty interesting to have a unique focus on radiation exposure as the main primary outcome across different modalities, and then doing sub-analyses of total radiation versus preoperative and intraoperative radiation, and then looking at CT versus fluoroscopy radiation doses. And also investigating surgeon-dependent fluoroscopy time was also interesting to see that wide variation. For limitations, this is retrospective study, and there was some heterogeneity in the distribution of the modalities and the surgeons. And it's unclear how generalizable this is, given that this was specifically using the Aero machine and the Excelsius machine, whereas there are other modalities such as WARM and the Mazor machine as well. And then using TLIF as a proxy for post-responding fusion can confound some of the secondary outcomes, such as operative time, since although I would suspect that perhaps setting up the CT, intraop CT, and redraping would add to the operative time, there wasn't data such as unilateral versus bilateral facetectomies and decompression that could potentially factor in for the operative time as well. For applications and future directions, since the MIS group had the lowest EBL and the shortest length of stay, but the highest amount of radiation secondary to fluoroscopy, an option would be considering MIS cases with CT navigation or robotic assistance, and investigating whether there is a difference in radiation from this specific combination. And even looking at robotic cases with intraoperative CT rather than doing preoperative CT and then merging with fluoroscopy in the OR, which could add additional radiation in this group. And in addition, potentially looking at greater than 1 or 2 levels of fusion would be interesting as well, since a lot of the time in the CT guided navigation comes from that O-arm spin and setup. So, the greater the number of fusions, really, the more you can dilute that time down across each level. That's it. Questions?
James, thank you. That was a great analysis of it. And I don't know, did any of the finding surprise you? Because for me, I was a little surprised that the MIS group was the highest. I always feel guilty because, we use navigation a lot. We use the robot. And I always felt guilty stepping out of the room and radiating the patient with that. But this kind of makes me feel a little bit better about that, because the MIS group using fluoro was the thing. And that was a little bit more surprising to me.
Yeah, I was surprised as well. I assumed that each spin would add quite a bit of radiation. But looking at the variation of fluoroscopy use per surgeon, I think if we look at the group that had the shortest amount of intraop use of fluoroscopy, that total radiation is probably lower than the CT navigation group. And really the averaging across with the surgeons who might be more generous with intraoperative fluoroscopy, I think kind of pushed that group over to the higher end.
Yeah. I know Dr. Kabesh has a question.
Thank you, Dr. Wang. For this study, my question was, while the MIS had double the radiation dose of navigation robotics, it led to a statistically significant decrease in the EBL, the length of stay, the operative time. Is there a role for including a discussion of this in the informed consent process? Should patients be allowed to have a say in which techniques that they're undergoing?
Thank you for the question. I think 2 parts about that. One, I think as I mentioned about possibly considering MIS cases with CT navigation rather than fluoroscopy, for example, that might be one way to compromise and get the better perioperative outcomes, such as lower EBL and shorter stay with reduced overall radiation compared to fluoroscopy. But I think that always patients should be part of the discussion in terms of which route they want to go ultimately. I think a lot of times patients come to clinic very set on wanting robotic or wanting, MIS or wanting navigation, and being able to kind of inform them about these data can certainly, I think, make the consent process more, comprehensive. So.
I thought this was a great article, and thank you for that nice discussion, Dr. Yu, and Dr. Kabesh, again, insightful questions. For me, the biggest problem with robotic assistance and all that is that we're using ionizing radiation that exceeds by far what we've had to do for conventional CTs. We, for instance, can't use helical CTs. We need to usually have 1 or 2 millimeter cuts. Most patients have some CT that they come with already. So we're duplicating studies, and just for the purpose of having some image guidance or a robotic assistance. And that's kind of the overlooked additional radiation burden. If we had perfect protocols, we would not duplicate studies. But the reality, my partner, Dr. Abdul Jabbar, who's using a robot next to me, is frequently frustrated by that. He can speak for himself, but we frequently find ourselves in the need to duplicate a study to have adequate image intensity for clarity. Isn't that right, Amir?
Yeah, absolutely. I think especially at this stage in kind of early integration, we've just recently gotten robotics here in our hospital system. It has played a big role in terms of my discussion with the patients, choosing to do an open case using fluoro instead of using navigation, because I don't want to have to expose them to a second set of CT scans. So that's definitely a part of my preoperative discussion. And I think, streamlining the system will help to minimize that. but it's definitely an issue, especially patients come from outside facilities with CT scans already completed.
We're at time. We have to come to a conclusion, but I wanted to take this moment to again reflect on the dire circumstances that your beautiful city is engulfed in, and recognize the extra effort that this must have taken emotionally from you to host this. So this was a terrific session. It distracts us a little bit and focuses on what we're doing, which is spine care. But thank you so much, USC. Thank you, Dr. Wang. And again, thank you all for your interest around the world and support of Global Spine Journal and its special mission. Jeff, do you want to close out with any final words?
Yeah, so first of all, I want to thank you, Jens, for driving this. I want to thank the Seattle Science Foundation for disseminating this, because I feel like this is very important. I want to thank everyone for coming and attending, and just say a few prayers for all the people in the Los Angeles area. There are countless colleagues that many of you know, we know very well, that have lost their houses, that have had to evacuate, and it's been a very trying time. So this has been a nice diversion from that, but please keep everyone in your thoughts and prayers. And thanks to everyone for doing this, and thanks to the USC team. I appreciate you guys getting up and doing this. Thank you.
Terrific group. Thank you.
All right, take care, everyone. Be safe.
Thanks.